It is just a huge, huge honor today to be podcast interviewing for the second time my best bud for years, Dr. Jay Reznick.
Good to see you, Howard.
My gosh, you are just the eminent oral surgeon on Dental Town. I mean, I don't know who else the hell it would be.
Well, there's Toof and Bifid Uvula. There's a few of us around.
Yeah, and
I think I've been around the longest, though. I'm the old one. I'm the old guy.
We launched Dental Town back in 1998, and right out of the gate, Jay was a townie, and for literally going on 20 years, you've probably answered, 5,000 oral surgery questions.
Has it been that long? Wow.
And sometimes I'll be reading a question, I'll just think, God, who could answer that? And so I hit forward and I email it to
your emails, yeah.
And he gets them 24/7 answer. He's just a saint. Dr. Jay Resnick is a diplomat of the American Board of Oral and Maxillofacial Surgery. He received his undergraduate biology degree from CAL-Berkeley, dental degree from Tufts University, and his MD degree from the University of Southern Cal. He did his internship in general surgery at Huntington Memorial Hospital in Pasadena and trained in oral and maxillofacial surgery at LA County, USC Medical Center. Dr. Reznick was one of the first North American adopters of fully guided, prosthetically based implant surgery and was the first specialist in the U.S. to integrate CBCT and CAD-CAM in his practice. He has taught dentists about basic and advanced implant dentistry, surgery, and 3D dental technology for the last 2 decades. Dr. Reznick has published extensively in the dental and medical literature and founded the educational website onlineoralsurgery.com, which has how many hours of content?
Right now we're up to 27.
27 hours. He does that surgery. He's got a camera on his head. He's got one on the pole. The assistant's aiming another. It's a three cameras. Three
simultaneous cameras.
Yeah. He lectures frequently at dental meetings and educational conferences, as well as giving live training courses to dentists from all over the world. Dr. Reznick is also a consultant to a number of manufacturers and suppliers of dental and surgical instruments and equipment, and is on the editorial advisor board of a number of dental journals. He is the director of Southern California Center for Oral and Facial Surgery in Tarzana, California.
Tarzana.
Like Tarzan. Samir, didn't he used to live there?
Yes, Samir used to be down the hall from me.
Yeah, Samir used to live there.
That's how we met.
He is the director of the Southern California Center for Oral and Facial Surgery in Tarzana, California. By the way, is that all on fire these days?
Not at the moment. Hopefully not. Hopefully, right now it's the closest fire is about 10 miles away.
You know, it's weird because in my 55 years, the fire season just used to be a couple months in the summer. Yeah. It's December.
Yeah. Well, we had really hot weather in November and October, November, and it's been really dry. And we've got these Santa Ana winds picking up, like 40, 50 mile an hour winds, and it's just the recipe for disaster.
Yeah.
So there's 6 big fires going on. There's one up in Ventura County towards Santa Barbara that's huge. Something like 140,000 acres. 140 square miles, I think, have burned.
Not to get sidetracked, I don't like to ever talk about religion, sex, politics, or violence, but you're a double doctor. I mean, you're a dentist, DDS, and MD. Do you think being warm this late in the year, do you think that is global warming man-made?
I don't know. It all goes in cycles. So.
You think it's just a cycle?
Yeah, because I just actually, as I was driving from my house in Malibu through Malibu Canyon to the office this morning, my thermometer on my car said 34 degrees in the canyon. So if that's global warming, I don't know. It was cold in the morning. So I think this all goes through cycles.
Well, I'm from Kansas, and they had a dust bowl storm there 100 years ago. That was like 3 years, no rain, everything was dust. That was before the car.
Yeah. These things all recycle. So, it could be we're getting a little warmer, but I think we're just going through normal cycles and then start cooling down again.
Yeah, read up on the Kansas Dust Bowl. They had a several-year drought, and the whole state was pretty much just dust. Yeah, we had a drought in California for like 6 years, and now last winter we had more rain than we knew what to do with. So, Jay, you teach hands-on Essentials of Implantology Level 1, 2, and 3. Well, let's talk about, what do you want to talk about first? You want to talk about your online first? What I want to guide this is here. I always ask you, send me an email, howard@dentaltown.com. Tell me where you're from, how old you are. 25% of you're talking to are in dental school. and the rest are all under 30.
Wow, okay.
I get like one email a month from some old senile guy that's over 50 and says, hey, dude, I'm as old as you. So they're in dental school. So they're going to come out of dental school, and here's their deal. They're all going to say the same thing. They're just going to say, I got $250,000 student loans, and we never placed one implant.
Yeah.
And then they need to pay their $250,000 student loans back, but they don't know, they didn't do any Invisalign. Should they go learn ortho? Should they go learn oral surgery? I like them to do the bread and butter need stuff. I mean, if you can't do a molar root canal and pull a tooth, you're in trouble.
Yeah.
So let's start with this. So let's just say that your daughter just walked out of dental school. She's 25. She's $250,000 in debt, and she doesn't know how to pull a molar. How would you start with that skill?
Okay. Well, first of all, I mean, as a specialist, I got to tell you that my training is a little different than basically dental school. So dental school, we're taught some basic skills, and in surgical residency and specialty training, you really hone that down, and there's a kind of a different mindset that I'll talk about. So what I would tell someone getting out of school is start off doing what you learned in dental school and become really good at it. And then as you start bringing more procedures in to your practice, like extractions, implants, what you want to do is you want to, first of all, you want to learn everything you can about that subject. Okay, you want to really understand it. So whether it's taking out a tooth or doing an implant, totally understand the procedure. Be able to get to the point where you can mentally walk through that procedure start to finish in your mind, anticipating all the possible complications and how you're going to avoid them and how you would manage them if they occur. And if you can't do that, you don't do that procedure. And that's something that we're taught in surgical residency. We're taught that you don't do anything unless you can complete it to the end. And so the same thing goes whether you're starting to get into extractions, if you're doing perio, if you're doing endo, if you're doing ortho. You need to totally understand what you're doing and have that mindset I always say think like a specialist, and just be able to do that mental exercise of walking completely through the procedure, understanding everything about it, and being able to complete the procedure. And then once you've done that, do 24 of those. And once you've completed those and you can do those in your sleep, then you go to something a little bit more complicated. Then something a little bit more complicated than that after you can do 24 of those in your sleep. And when you do that, you're going to have success. And you're going to have happiness. You're not going to be stressed. You're going to sleep at night. And the bottom line is you're going to do what's best for your patients. Just because something walks in your door doesn't mean you have to do it. That's why specialists are there. And you want to have a specialist that you work with closely, that's sort of like a mentor that will help you, because there's plenty for all of us to go around if you want to be doing these procedures. But the bottom line is learn to do it the right way and grow the right way. Don't think just because you put in a single tooth implant with a tissue punch that the next case you can do is a fully edentulous case. You're really kidding yourself, and you're going to do everyone a disservice, your patients and even yourself, because you do that, you have a disaster, you're never going to want to do another implant again. If you start with a simple extraction, all of a sudden you have a full bony impaction that you want to try, and you have a complication, you're never going to want to do another extraction again. Same thing with ortho, endo, etc.
And I think half the specialist, or half the dentist, half the humanity, thinks in fear and scarcity, and the other half think in hope, growth, and abundance. You need to find an oral surgeon or a periodontist in your own zip code or county that, if you call them up and say, I'd like to come watch you learn how to place implants, he says, no, refer him to me. I'm not going to teach you how to do this.
Yeah.
Just cross his name off
go
and
somewhere
never
else.
call him again. Call the next periodontist. He'll say, yeah, come in. And then when you got an open schedule because you just started your associate job and you don't have anything going Thursday afternoon, call your periodontist, call your oral surgeon. Can I come sit by you?
Yeah, exactly. I think,
or endodontist.
I mean, the good oral surgeons, good specialists, oral surgeons, periodontists, orthodontists, are all very comfortable with what they do. And they get it. They understand that there is plenty for all of us to do. And we all benefit when the general dentist is understands implantology, understands ortho, understands endo, because it's perfectly within your training and it's within your your wheelhouse. You're smart enough to do it, and you have the skills. You just have to do it the right way, and there's enough for us all to do as long as we do it the right way. And a smart specialist understands that, and will mentor the GPs who follow that. If you're doing things that are beyond your training, beyond your skill set, or just that you really are not prepared to do, they're not going to want to help you. But if you make it very clear that I want to watch you, I want to see how you do it, I want to do some simple cases and help, and as a result, using implants as an example, some of my best referrals are dentists who now place implants, because maybe 10 years ago they would have done, let's say, if a patient's missing 6 teeth, they would have done a bridge or removable. Now they're thinking, oh, this is a good implant case. Patient's going to need some bone grafting, but this will be a good case. I know just who to send this to. And as a result, my referrals for complicated implant cases and bigger implant cases has improved. I'm not doing as many little cases, single tooth implants, but I'm doing more of the bigger cases, which are, as a specialist, are pretty fun.
I know orthodontists in many, many different major markets where when Invisalign started taking place, 10, 15 years ago, they thought, okay, these guys are going to do it.
Yeah.
But they don't know how to do it.
Yeah.
So all the other orthodontists were afraid of Invisalign, and you'll get one that thinks in Hope, Growth, and Abundance data that tells every dentist within 20 miles of them, I'm going to have an Invisalign study club.
Yeah.
And I'm going to come and bring your cases. I'm going to help you do these cases. So what did all those dentists turn into? Refers.
Exactly.
And they built the biggest
Exactly.
the biggest practices ever.
Yeah.
And those orthodontists tell me the same thing. They go, once they started learning ortho and doing some Invisalign, they started seeing ortho.
Right, exactly.
So they just started diagnosing the heck out of it. And if you do a little, the best thing for me.
It's a win-win for everybody.
When I was got out of school, I went and did Carl Mish's 7 3-day program.
Yeah.
And what changed my mind is when I walked in there, I had this belief that a sinus lift was just crazy. I mean, we're talking back in the 80s.
Yeah.
But watching Carl, it gave me faith that this procedure.
It's such a routine procedure, and I did one today before I got on the plane. It's very, as long as you understand it, understand the physiology, understand the procedure, it's a very safe, reliable, predictable procedure. And most patients have very minimal swelling, minimal discomfort, really very few problems afterwards.
But would a sinus lift be something, again, we're talking about a quarter of our listeners are in dental school, 3/4 they're all under 30. Do you think in the first 100 implants a sinus lift goes in that category?
No.
Okay.
It's not something you're going to do until you're very comfortable. So
the first 100... There's not going to be there's not going to be any PRF.
Yeah, are you
going to be drawing blood?
No, not
making sticky bone.
Not until you've done at least 100 implants do you even start thinking about doing some advanced procedure.
And you're going to stay out of the aesthetic zone. That was my first big mistake.
Yeah.
One of my first, I think it was like 5th ones on this gorgeous blonde girl on number 8. Thank God I had a prosthodontist I could bribe to go fix it. But stay out of the aesthetic zone. What are your, in the first 100, what are your favorite teeth to place?
I think at least for the first 25 for sure. First premolar to first molar. And the first 25 should be flapless surgery, which means you've got plenty of bone, plenty of keratinized tissue. You don't even have to think about laying a flap.
Really?
In the next 50 or next 75, then you start from a very simple flap, very small incision, some minor bone grafting, maybe an indirect sinus lift as you get more advanced, and simple suturing. And then once you get to 100, then you can start building on that foundation of what you know and your skills, and start doing more complicated bone grafts, sinus lifts, etc. So in the courses that I teach, Essentials of Implantology,
1, 2, and 3,
we have
right?
we have 3 levels.
And are those 2-day courses?
They're all 2-day courses, and we have 3 levels.
Where are they at?
We're doing them all over the country. So we're doing one in February here in Scottsdale, and we're doing one in March in Dallas, and we've got dates coming up for the whole rest of 2018. 2019, we're going to expand it even further and probably have an implant continuum, where you bring your cases and we do the surgery together. But we have 3 levels. So we have level 1, and that's for the dentist, the newbie dentist when it comes to implants. You haven't done a single implant before, or maybe you've done 2 or 3 or 10. So 0 to 25 implants. We start you off learning the basic principles of implantology. You know, what is type 1, type 2, type 3, type 4 bone? You know, what do we mean by biologic width in relationship to implants? Talk about the science between using short implants, long implants. You know, we talk about, you know, basic bone physiology, how you drill, drilling speed, what drilling speed you use and why. And so it's very, very foundational. And we teach you first premolar to first molar, flapless surgery, plenty of bone, plenty of keratinized tissue. And we tell you that's all you want to do for your first 25 cases. And once you've done that, then you come back and do level 2. Or if you've already done that in your experience, you come in for level 2. In level 2, then we start bringing in small incisions, maybe a little bit of particulate onlay augmentation, indirect sinus lifts, maybe taking on a lower second molar where space is a little bit more limited. Maybe towards the end, anterior aesthetic zone in a very straightforward case. And start talking about extractions with immediate implant placement. But the first 2 dozen you do, if not more, should be very, very basic. Healed ridges, flapless surgery. Okay.
And would these be?
And then level 3 would sort of be expanding with open sinus lifts, ridge splits, bigger cases.
Patients always want, you know, to leave with a tooth. In these first 100, would these be 2-stage implants? Would these be immediate load?
Well, the first 25 that you do are going to be implant is placed in a healed ridge with a healing abutment or a cover screw. That's it. That's as far as I want you to go, because I want you to be very comfortable at working up and treating this very simple, straightforward case before you start moving on to something more complicated. Okay? Immediate provisionalization, immediate loading, wherever you want to call it, is, you know, has a higher, well, actually, it's just as successful, but it's a little bit more technique sensitive. So you want to make sure you've got the fundamentals. Immediate extraction sites, implants in an immediate extraction site. Again, you know, very high success rate, as high as placing an implant into a healed ridge. But again, the technique is a little different, and you've got to master the basics first before you move on to something more complicated. Okay? So I would say after you've done at least 50 implants, then you can start doing immediate implant placement in extraction sockets. Start possibly, you know, doing immediate provisionals, and then work your way up once you've got those 2 skills mastered, put them together, and do an anterior aesthetic zone, extract number 8, immediate implant with immediate provisional. But very slow, stepwise, very deliberate. You know, it's like in my residency. I didn't start off, you know, taking out impacted wisdom teeth. I didn't start out doing mandible fractures and orthodontic surgery. We started out very basic. We did, you know, basic surgery, surgical extractions, then progressed through the year to do impactions. And then from simple soft tissue, partial bony, full bony. Second year, we start doing trauma, pathology. Third year, we start working at orthognathic, TMJ. But again, when we learn in residency, we have a mentor. We have our attending staff. We have our senior residents who show us how to do it. And then we watch them do it. And they do it with us. And then they watch us do it before we do it on our own. So it's a very different mindset than the way we are taught things in dental school. Okay? And so one of the things that can get you into trouble as a general dentist, if you're starting to get into doing surgical procedures or any kind of specialty procedure, is getting outside your boundaries, getting outside your comfort zone. When you look at a procedure that needs to be done, whether it's an Invisalign case or an endo or an extraction or an implant, you look at the case and you go, I think I can do that. If that's what you say, you don't do it. Only if you can say, I know I can do it. That's when you can do it. And you can only say, I know I can do it until you've had the fundamentals, the basics, and some experience under your belt of the really simple stuff, and then you've slowly progressed into the more advanced.
So I've heard you lecture a gazillion times. I've read all your 5,000 posts for 20 years. I know where you stand on this, but I still have to beg the question. This is Dentistry Uncensored. So she comes out of school, and she's working for her old man out in the middle of Hayes, Kansas. He's placed 1,000 implants with a pano, and he's like, Jay, seriously, here's the truth. I would say 80% of every living dentist who's placed over 5,000 implants did them all with panos.
Yeah, well, I did too.
Yeah.
My first 10 years of practice, I did it all with panos. Because that's all we had.
So let me continue this rant because I've got this email 100 times.
Okay.
And then when she talks about surgical guide, her dad's like, what do you need? Training wheels on your bicycle? You need 3D and training wheels? Dad's placed 1,000 with the pano. What would you say to her dad listening here right now?
I would say it's time to advance yourself a little bit. So, how many things that we have that we do in our life are we doing the same way we did 20 years ago? Okay? Perfect example. Okay?
Yeah.
20 years ago, who would have dreamt? I mean, if I had to write a paper, if I was writing an article, I would get out my typewriter with my Smith Corona with the eraser cartridge, and I would spend time typing, and then have to correct and then redo it over and over again. That worked great. It was fine. But with a word processor, with templates, how much easier and how much more efficient is it to do now? Okay, I can place an implant. I can place 10 implants with a pano and freehand. Okay, but with cone beam, I have much more information to understand the anatomy. So where the sinuses are located, where the nerve is, what the width of the ridge is. I don't have to flap it open and say, oh, it looked like the ridge was like this on pano, but in reality it's like this. What do I do now? I know ahead of time what I'm getting into. Okay? I can place 10 implants with that guide in less than half the time with greater accuracy and precision than doing it freehand, no matter how many implants I've done. Okay? I can do it with better efficiency, safer for the patient. Okay? I don't know if you remember, but there was a time where there were a number of case reports of implants being placed through the lingual cortex of the mandible. Because remember how you have the mylohyoid concavity? Implants placed, the nerve was way down here, but the concavity came like this, and implants were placed into the floor of the mouth, resulting in floor of mouth bleeding, airway obstruction, and death in the dental office. Wouldn't you want to avoid that? Would you not want to have that headache? Or with sinus, you can't tell in 2D what's going on. The patient's not a block of wood, they're a three-dimensional person. 3D imaging gives you more information, more accurate information. So the analogy that I use when I lecture is GPS. Okay? Guided implant surgery, 3D imaging is like GPS for placing implants. Okay? So you may say, well, I can drive from here to the airport without GPS, right? And I can drive from here to my office without GPS. I've been doing it for 10 years just fine. Right? But what other information does that GPS in your car give you?
How far away the girls on Tinder are.
Okay. Other than that.
By the way, did you know Phoenix is the test site for Google's Waymo?
Oh, really? Okay. Well,
So,
you'll have to tell me about that after we're
Yeah,
done.
and Awatuki, there's driverless cars now. I mean, you see one every other day.
Wow, that's amazing.
But back to GPS.
So what's missing, or the thing that I didn't mention, is real-time traffic. So if you put that real-time traffic information together with the GPS data, what do you get? You find the best way to get to your destination, the most efficient, the least stressful way, and the quickest way to get there. So guided implant surgery is like GPS with real-time traffic. It gets you to your final destination more efficiently, with less stress, and more accuracy.
Jay, when we were little, 30 years ago, the goal of the implant was the longest one you could get. I mean, people would move and figure out liver nerves over just to get the implant 5 millimeters longer. Now they tend to be trending to go shorter and fatter. Are you personally doing less sinus lifts and
we're doing less grafting because what the studies are showing us, and when you look at the stress patterns on implants, and you look at the long-term success of short versus longer implants. So if you have 6, 7, 8 millimeter implants, and you compare them with placing 11, or let's say 10, 11, 13 millimeter implants, where possibly you have to graft the site to be able to put that longer implant. What the studies have been showing is that the success rate of that short implant is just as good as that longer implant, except that when you did the grafting for the longer implant, that has a higher complication rate. So it's made us rethink a lot of what we were what we were learning before, what we were doing. We always wanted to put the longest implant possible. Now what we're finding is that short implant, and if we can go wider, great, but a shorter implant is just as successful as the longer implant. And if we don't have to graft to be able to place that shorter implant, our complication rate is lower. Okay? And
that was a beautiful story. It almost made me cry. I love it when the short fat guy wins.
That's been my story. And the same thing we've learned is with insertion torque. We used to think the tighter you could crank that implant in, the better it was, right? But now we know that those higher insertion torques cause necrosis of bone and more remodeling, and that may be one of the things that was leading to bone loss and implant failure. So now we put in implants we prep our sites differently so we can place those implants in at lower insertion torques.
So back to that little 25-year-old girl going in with her old man or her old mom, and they're going to get a CBCT. I mean, the major ones are Galileo's from Dentsply Sirona, iCAD, Carestream. What advice would you give her on which one to get?
I think if you look at them all, they all pretty much give the same image. Okay, you look at you go to the different implant or different cone beam manufacturers, and they're going to show you all these cases on their computer, and they're all they always pick the best images to show you.
Yeah.
Okay. Every cone beam out there can give you some amazing images on your patients, and it can give you some horrible images. And it has to do with how much metal's in the patient's mouth. It has to do with the patient's density and all kinds of factors. Okay, so they all give you good images. What I tell people to look for is you want to have software that's easy to use, that's user friendly. Okay. Because if the software is cumbersome to use, you're not going to use it. Okay? If it's a pain to navigate through those volumes or to plan those implants in the software, you're going to stop doing it because it's too complicated to learn and it's taking too much time to do with your patients. Okay? If you have a system, let's say, where it's hard to get training or it's hard to get support, that's going to be a problem too. You're going to stop using the technology. You want to go with a system and go with companies that give you good support and give you training as part of the package.
And who do you think does that best?
I've been working with Sirona, now Dentsply Sirona, for 10 years.
Well, here's
I went
the way
with them for those reasons, and I think they still are the leader in those two categories, support and software and innovation.
Well, the way I see it is it just goes back to Apple or Android. Basically, the open-close. Apple's completely closed system, but like Dentsply Sirona, but the CAD/CAM talks to the CBCT, and it's really simple.
Seamless.
It's seamless and simple.
But they are opening things up.
So then you have these other
that's
people,
happening in the last year or so.
There's these other people who say, well, I want to mix and match printers, CAD/CAM, CBCTs, and that's cool if you're a really sophisticated techie.
Exactly.
But I've gone into so many offices where they want to do the open system. They got all these machines, and then you go ask anyone in the staff a simple question, and they can't figure it out.
Yeah, exactly. So you want to do a
and when people start bad mouthing that the closed system is so bad, it's kind of funny when they're saying that when they have an iPhone.
Yeah, exactly. Yeah.
So an iPhone and Galeos, which is owned by Dentsply Sirona, I think it's closed system.
I think it's a great analogy.
And it's intuitive like Apple.
Yeah.
But if you start mixing and matching pieces, that's super cool if you're a nerdy TED.
Yeah, and if you have the time to figure out how it all works together. I don't know if I told you how I first started speaking for Sirona 10 years ago. Is Sam Peri, had worked with them on CEREC, and he introduced the.
I thought you met him on Dental Town.
No, I met Sam because he was down the hall from me.
Oh, okay.
He's the one that brought me into Dental Town.
He met T-Bone on Dental Town.
Yeah, he met T-Bone. Yeah.
So that's right. He was down the hall from you.
Down the hall from me. So he introduced the imaging Germans to me, and when they were coming out with the software, when they were coming out with Galileos, they were going to be providing a speaker to my study club that I do once a month for my practice. And so I was told that before the meeting, they wanted to meet with me. So I met with them at the venue, and they sat down and they showed me the software, the Galileos implant software, and had me play with it for about, they took about 5 minutes to show it to me and let me play with it for about 15 minutes. And so I said, okay, this is great. This is really easy to use. I really like it. When's the speaker going to be here? And they said, you're the speaker.
Ha!
You now know everything there is about this software and how easy it is to use and intuitive. I want you to talk about it for an hour in front of your referrals. And I did, and that's how it all got started about 10 years ago. And so I've been with them ever since. I did the very first live guided surgery with the Galileos implant system live on stage at the Scottsdale Center with 500 people there. And
nice. How many years ago was that?
Well, it's going on 10 years ago.
Wow.
Yeah, it's.
Have you ever been to Sirona in Germany?
Yeah, been there a few times.
What's that city called?
They're in Bensheim.
Bensheim. I'll tell you what. If you've never been to Germany or Tokyo, you. Yeah,
it's amazing. Bensheim is where they have Sirona,
I've been in 50 U.S. dental companies minimum. I mean, Germans and Japanese. I mean, they're the only two countries that make a car. I mean, you'd only want a German Volvo.
Well, the Swedes, yeah.
What do the Swedes make? Oh, is that Swedish?
Yes,
Volvo?
Swedish, yeah.
Okay. But, I mean... and
there's Italians. Italians make cars.
But Mercedes and Porsche and then... I mean, here's the difference. When you go into a German deal, like you don't have to ask questions like where's the bathroom. There's a blue line that takes you to the front. There's a red line that takes you to the bathroom above every switch. And what blew my mind the most, you totally get German manufacturing if you remember the space shuttle. Remember when they rolled out Space Shuttle Columbia? Had this big old huge black arrow 10 feet wide by the fuel deal. And I remember looking at that thinking, they're astronauts, they're scientists. Yeah. There's no big arrow pointing to my gas tank. Why the hell do these guys need an arrow pointing to a gas tank? And it's like, that's German manufacturing.
Yeah.
It is another thing. You walk into almost every American dental manufacturing company, they have not one person with a PhD or an R&D. but they got a 30-person call center.
Yeah.
And then you go to the German and the Japanese companies, and they have 15, 20 PhDs, and they don't have a marketing department.
Yeah.
So the Germans and the Japanese think we will make this so damn good it'll sell itself, and the Americans are like, I can sell anything to anybody with my telemarketing skills. But German and Japanese.
Yeah.
So I want to go back to another thing. So you like the Galeos with the CEREC because it's a closed
system and it just all works seamlessly.
And the CareStream and the iCAD are very popular too.
Yeah.
But you need to be they're not as user friendly.
They do have solutions to integrate CAD/CAM with cone beam and make surgical guides, but they're a little bit more cumbersome.
Right.
And they don't always work as well.
So know your own wheelhouse. If you're that techie, nerdy, geeky guy that can wire and splice everything together, you'll be fine.
Yeah.
The other thing, I recommend that the implant system she picks is I recommend that she picks a mentor in her county first and then use that system.
Right.
But you work with Dentsply Sirona and BioHorizon, and Dentsply has they have the Astrotech, they have the Freelit, they have the Xive, and BioHorizon. If she was asking you, Jay, what implant system should I start with? Does it matter if it's one of the big 6 brands?
I mean, my bias is always go with a name brand, especially starting out, because you've got the company behind you. You've got the reps that are there in the field to come help you and show you the ropes and make it easy for you. A lot of the systems are very similar. The connections are a little bit different. The screwdriver's a little different, but they're all pretty much the same. So if you go with the big names, Astra, Nobel, BioHorizons, Straumann, all those implant manufacturers are giving you high quality products. They also have the research behind them. Some of the budget brands don't have their own research. They're kind of piggybacking off of, let's say, Nobel and saying, well, it's just like Nobel, so it must be the same. But there are subtle differences. And what we're finding over time is that the very subtle differences in surface, in alloy, and screw pitch, design, etc., do make some differences. And so I always recommend go with a name brand and go with, again, the company that's got good reps in your area. And that varies geographically. There are some areas like, some areas BioHorizons is the strongest, and they've got really good reps. Or
they're out of Birmingham, Alabama.
They're out of Birmingham.
Yeah.
Or in your area, the best rep may be with Nobel, or maybe with Straumann or Astrotech. So you want to have a really good rep starting out.
Here's I like to look at what do the successful people have in common. Every dentist I know that has placed 100 implants or more have a very close relationship with a rep.
Yeah.
And then everybody who just there says, well, I'm going to buy it online. I'm going to save 25 cents. Yeah, go save a lot of money.
Yeah.
But you just never get it done.
Yeah.
And the other thing I've noticed is that, in 1900, there were no specialties and the doctor did everything.
Yeah.
By 2000, there were 58 specialties with MDs and 9 with dentists. I've also noticed that there's a critical mass on probability that if you don't do it once a week, you don't reach critical mass.
Yeah, or
so
even more than once a week. Yeah, absolutely.
Yeah, so if you're going to get into implant dentistry, you need to place one a week. You're going to get Invisalign, you need to do a case a week. The procedures that you do once a month or every other month, when you factor in all the continuing education, all the overhead, all the costs, you lost money.
Yeah. I mean, I'm fully trained as an oral maxillofacial surgeon. I can, take apart your face, put it back together. I can, do TMJ surgery, orthodontic surgery, tumor surgery, you name it. I train doing all of it. But I don't do those as often. In fact, I stopped doing TMJ surgery because, 90% of the patients who came to me with TMJ problems got better with nonsteroidals and splints. 90% of those that didn't got better with arthrocentesis. That left about 2 or 3 patients a year that actually needed surgery. You can't be good at a really complicated surgery like TMJ surgery if you're doing it 2 to 3 times per year. Same thing when it comes to cancer surgery, orthodontic surgery, all of those things that are part of my specialty. as my practice has evolved and I've spent more time with education, with online oral surgery, with lecturing, and I'm not in the office as much, I'm just not doing those procedures that I'm fully trained to do, and I've done dozens of. Since I don't do them on a regular basis anymore, I stopped doing them. And so especially as you're starting to get into procedures, that's why I say start very basic first. Do those simple cases and do them well, and then progress. Don't ever get in over your head. And like I said, don't tell yourself, I think I can do it. You have to say that you know you can do it. And being able to know you can do it comes from having done it a number of times. And when I was in general surgery residency, I remember one of the attendings would always tell us that that good clinical decisions in surgery come from clinical experience. Clinical experience comes from having made bad clinical decisions in surgery. Okay, you don't want to. Hopefully, you don't want to make bad decisions, but you will have the most success if you start off very basic, get that under your belt so you can do it in your sleep, and incrementally expand and grow.
No doubt.
Yeah.
So you're saying pick a system that's got research. Do you think, the one thing Americans dentists don't talk enough about is there are 1 million attorneys in the United States, and they bill out $1 trillion a year. So when you look at our $19 trillion economy, $1 trillion of it's 1 million lawyers.
Oh.
Do you think if you're sitting on let's say you do an implant case, the implant snaps or whatever, and it goes to trial, and it's not Noble BioCare, BioHorizon, Straumann, Dentsply, Sirona, Astrotech, big names, and because like Italy, Italy has 100 different dental. But you think if you get a no-name knockoff generic that could look bad in court?
This is something we actually in our Essentials of Implantology Level 1 we talk about, because one of my goals in the course is to have you never be in court, but if you are, that be able to defend whatever you did. And I was an expert witness. I was both for defense, mostly defense, but sometimes plaintiff if it was really an egregious case. I was a medical expert. I did a lot of expert testimony, and one thing that I learned from doing that is that a malpractice trial is not a trial by a jury of your peers, for one.
Right.
Okay, it's of people who don't know anything about what you're doing. They think you're a rich dentist, and
they are rich dentists.
And it's not about whether you did everything correctly into the standard of care. That doesn't matter. What determines whether you win or lose in court is which side puts on the best dog and pony show. Okay, so one thing you want to do is, if you're doing any procedure, whether it's general dentistry or specialty procedure like implants, ortho, endo, is that you always need to be able to defend what you did, and you need to do it to the same standard of care that a specialist would do. Now, when it comes to things like using a knockoff implant, well, not real knockoff, but not one of the big 6 implants, okay? That may not have had anything to do with why the case failed or became a disaster, so you end up in court. But I can guarantee you that the plaintiff's expert will make it an issue.
So you just said the big 6. In your mind, what are the big 6?
Well, I think Astrotech, Straumann, BioHorizons, Nobel, 3i, what are we up to? That's 5, and let's see, what's another big one? Let's see, 3i.
Implants Direct?
No, they're basically a knockoff. So let's call those 5. Let's say 5.
Did 3i get swallowed by Zimmer?
Well, yeah, it's owned by Zimmer, but it's still 3i or Zimmer, Biomet, 3i.
So 3i Biomet, that's Zimmer. So you're saying Zimmer, Noble BioCare, BioHorizons, Straumann, Astrotech,
and those are the major systems out there.
Okay.
Yeah.
Let's talk the controversies. Cement or screw? A lot of.
something.
Jay, are you a
something
cementer
easy.
or a screwer?
Well, I would say that you should plan on doing a screw retain restoration as much as possible. It's a lot more retrievable if you have to get the crown off or the prosthesis off, but it also avoids the issue of cement sepsis and cement, getting under the tissue,
But isn't it kind
and
of
causing bone necrosis.
But isn't that kind of a dental manufacturer's? Isn't that just insane that they make a cement that says dental implant cement?
Well,
And if you have a little excess, it causes a disaster.
well, because because what happens is cement violates the biologic width. It gets where it's not supposed to be, and it sets off an inflammatory reaction. So one thing I learned in dental school in Crown and Bridge was you use as little cement as you need, and you cut that in half, and that's what you use. Okay, and if you follow that, if you're doing a cement retained restoration, chances are, if any cement oozes out your margin, it's going to be very minimal, and you'll be able to see it. Now, what we tell people in our course is, if you're going to do a cement retained restoration, keep your margin no deeper than 1 to 1.5 millimeters subgingival, so that you can really see and clean out any excess cement. Okay? Or supragingival would be even better if you can, if you're in the posterior. But the one thing about being able to do screw retained restorations, especially in the anterior aesthetic zone, is that this is where I think that 3D imaging and guided implant surgery is so critical. Because what you're doing when you're doing cone beam imaging and treatment planning in the software and then creating a surgical guide is you truly are planning the implant position based on the final prosthesis. And then you're using these tools to deliver the implant in exactly that spot, so that if you plan the implant to be right here, it's right here. It's not just a little bit off, where you thought you were going to do a screw retained restoration and you end up having to do a cement retained, or because the implant's a little bit off. Guided implant surgery is a tool to place that implant more accurately and precisely on a consistent basis. So if you're basing your plan on the final prosthesis. So that's why, we get back to, Panorex and freehand implant placement. Sure, you can do it that way, but if you want that accuracy and consistency of good results, then using the technology that's available to us in 2017 is the way to go, not the technology of 1985.
And you think you can freehand it and line it butt up, but you know what? Every lab man I know who's done 10,000 crowns can tell 100% of the time if the dentist was right-handed or left-handed. They place the implants.
Yeah, oh, absolutely.
It's a right-handed guy. It's all freehand. All the implants are drifted towards the dentist.
Yeah.
Which website would my homies find most of your information? Like, you're saying these courses are in Scottsdale and Dallas.
Well, we have everything on onlineoralsurgery.com.
Everything's on onlineoralsurgery.com.
And then we've got some links on the homepage for essentials of implantology, and then any live lectures that I'm giving. So all the information is on the homepage of Online Oral Surgery. And also we have on the website, we've got, as we mentioned, 27 hours of online content. That is dental alveolar surgery, impactions, pathology, radiology, and implants. And we're expanding our website to bring in more faculty members. So we're going to have an oral maxillofacial radiologist.
Who's that going to be?
It's going to be Dr. Heidi Kohlfarber, who's out of Loma Linda. And also at UNC Chapel Hill, we're going to have an oral pathologist from USC. Dr. Audrey Boros is going to be on our faculty and helping us build our content. We're also going to have Chris Ferrugia, who's a dentist out of Pensacola, Florida, who specializes in medical billing. And we're all going to have, they're going to be doing courses with us to give not only how to do the surgery, but also to learn about pathology, radiology, and of course medical billing, so you can get paid for some of the procedures that you're going to learn from the website.
So how much is onlineoralsurgery.com? I'm on your website right now.
It's $50 a month, or the better deal is to do an annual subscription for $4.95. So
No, you don't want to do that.
So it's like getting 2 months free.
No, you don't want to do that.
Why not?
Because the whole deal is your marketing and advertisement should get them on a reoccurring revenue.
Well, it is.
Right?
It's an annual recurring. So
Well, you don't want to ding them $4.95 once a year. You want to ding them. What is it? How much a month?
$50 a month.
$50. So you emotionally want to make that $49,
Okay.
and then it's a reoccurring.
$49.95.
Because I mean, look at these deals. Like Apple realized they lost tens of billions of dollars because they would sell you a song for 99 cents. And then Spotify said, no, let's use all that marketing to get you to sign up for $4.95. Look at Netflix. It's worth $70 billion because once you join it for Netflix, like I have Netflix. Ryan, when's the last time I watched a Netflix movie?
I don't know if you ever have.
And I'm on Pandora and Spotify. I haven't listened to Pandora, but and Lifetime Fitness. Look at me. I look freaking pregnant with twins. But Lifetime's dinging me every month for membership. Spotify, Pandora. That Netflix is one of the top 5 biggest companies because when they decide they're gonna cancel, they're driving to work and they're like, you know what, I'm gonna cancel Spotify. I never use it. Okay, you have that thought, but you're driving to work. Humans can't get it done. They're not organizing.
Well, okay. So if you want
of dentists can't even reconcile their bank statement.
True.
What percent?
All right, so if you want to spend $600 a year, do a monthly, you can.
You only offer the reoccurring revenue. You
they're
only
both,
offer for $49.
They're both the monthly and the annual are recurring. But the advantage we're always adding new content.
Yeah.
And starting actually next week, we're launching. Not only can you go on to the website
if you ding them a year later for $500, that might motivate them to sit down and call you up and cancel and get off the deal. But the little $49, they know they need to watch
actually,
it.
we get more people who cancel their subscription on the monthly than on the annual. But anyway, but we're going to start providing online CE through the AGD PACE certification. So not only can you get on online oral surgery and learn something, you can actually get CE credits to help renew your dental license. So that's another thing that's happening too.
And what is Medicus Multimedia?
That's just our parent company that runs the website and our educational courses.
And is that your company?
Yeah.
And is that where you live, Pacific Palisades?
That's where my P.O. box is. I actually live in Malibu.
Do you live in Malibu? Didn't Fred Joyle live in Malibu?
He lives, no, I think he lives in South Bay somewhere. I think he lives in like Huntington Beach area.
My boys still talk about that.
Or Manhattan Beach.
We got an RV and we left Phoenix.
Or Hermosa, one of those.
We drove to Fred's house in LA, and then we drove all the way up the beach all the way. And we saw Ken Austin. And
you probably drove right by my house.
Oh yeah. And they still this day thought Fred Joyle was the coolest house I'd ever been in.
Yeah, I'll bet.
Let's talk about more. Controversies.
Okay.
There's a lot of research saying that at 60 months, 5 years, 20% of these implants have peri-implantitis, and at 9 years, 36% have peri-implantitis. What do you mean
the other way around?
Well, at 5 years, it's up to 25%.
Oh, 25, okay.
And at 5 years. And at 9 years, it's up to 36%.
I would say that is absolutely spot on. As we are learning, as more and more implants are being placed, we're seeing more and more peri-implantitis. And so actually one of the things that we're doing in our practice is we're actually focusing on peri-implantitis. So we have patients that are referred to us from all over LA, all over California, all over the country to manage peri-implantitis. So we use all the technology that's available to us using lasers, piezo surgery.
Using lasers? Mm-hmm. Now, is that LANAP?
No, we're using the BioLase.
You're using the BioLase?
Yeah.
And why are you using the BioLase instead of... Which one's the LANAP?
That is the Millennium.
Millennium.
Yeah.
So why did you go with BioLase instead of Lenap with Millennium.
The studies I've shown showed a higher success rate of being able to sterilize the implant surface, and also being able to regrow some bone around the implants. So that seems to be very effective. We're also looking into using the piezotome, piezosurgical instruments for debriding around the implants, as well as some of the basically the grip blasting with blanking on the material. But we're looking at all the new technologies for treating this problem, because we're seeing it as an emerging issue that's going to start haunting us in implantology. And we want to be, in our practice, we're kind of positioning ourselves at the forefront of managing these complications.
So,
and reversing
so when
them.
you manage these peri-implantitis, will a laser always be part of the protocol?
Well, I'm not going to say always, because for right now, the technology that we've researched and we're bringing to our practice, that is the most effective. So that at the current time, that's what we're using. As technology changes, it may be that we find something else that's better than laser, in which case then we'll switch technologies.
Do you think some implants and their surface are more susceptible to peri-implantitis than other implants?
I think probably, yeah.
Because remember when we started 30 years ago, remember it was the HA coating, and then that was all falling off and showing up in kneecaps and macrophages. And
and there was an implant system that I placed that was had a very large, like a porous surface, that had a large surface area which allowed you to place very short implants with a high success rate. The problem was, because of the surface, if you had a little bit of bone loss, once the bacteria started getting into that porous system, you had massive bone loss, including spread to adjacent teeth. So definitely the implant surface does make a difference, and I think we're learning more and more about those things as time goes on. Possibly different titanium alloys may make a big difference as far as peri-implantitis. So we're just at the tip of the iceberg, learning now that we're seeing peri-implantitis as not just a rare occurrence, but as being something that we almost should expect and prevent from the time the implant is restored. Now we're seeing it as something that is something completely different. So our knowledge is changing, our perspectives are changing, the technology is changing, and this is all evolving.
But you know what's not changing? The patient and the treatment planning. Because if they could walk in there and snap off their denture and brush their implants, but that's not what the dentists are doing, because the patient wants it fixed. Then they come in your office, they have a full loaf of bread underneath their all-on-4 implants. I mean, if you spray water in there, you got to turn your head. It's just, and how many implants have you had in your own mouth?
None.
Yeah. The vegan yoga instructor isn't the one getting implants.
Right.
I mean, why did these people lose their teeth to begin with? They weren't taking care of them. They were brushing, smoking, alcohol. So the patient selection
is critical.
Is critical.
Yeah.
I think everybody.
I don't do a whole lot of. I don't really do that many all-on-4s. I used to do them,
but it's not even all-on-4. I mean, if you had the pattern, the behavioral patterns to lose a bunch of your teeth,
exactly.
I can go give you all new teeth, but you're still Uncle Joe.
Yeah, you're still not going to floss. You're still going to.
And I want to talk about my implant failures. Looking back, it's really sad to me when a patient calls in and their mom's in a nursing home. And you go in there and you did 2 implants. You got rid of her partially. You did 2 implants, 2 3-unit bridges, and she loses 20 years later. She loses one of these implants, and I'm sitting there thinking, if I would have placed 3 implants and a 3-unit bridge, I wouldn't have lost the case.
Yeah.
And 20 years later, I've lost a half dozen bridges because I put 2. So now I'm like, do you treatment plan 1 implant per?
Well, I always, and one of the nice things again about using the technology and the software with cone beam and implant planning software is I can show the patient the differences. So I can show them, look, you're missing 3 teeth. We can place 3 individual implants and have 3 individual crowns, or we can place 2 implants with a bridge. But with a bridge, you're going to have the same problem you had before, is that it's hard to floss underneath there. And if you lose an implant, then you're stuck with 1 implant and 2 missing spaces. So if we do 3 implants, or if we have 3 implants and they're individually restored, then it'll be easier for you to keep clean. And if we lose an implant, then there's still a prosthetic option that we can do even temporarily while we're waiting for another implant to reintegrate. It's going to cost you more up front. The prosthetic cost is probably going to be about the same. So you're talking about the difference between 2 versus 3 implants, but it keeps your options open. I think it's going to be better for you long term, and you're investing a lot of money into your mouth to do this to begin with. Don't you think it's worth the difference?
Yeah, you got to have spare tires, because here's what here's what you don't know when you start your practice. When you start your practice at 25, you don't ever believe that someday you're going to be old and fat and bald like me and be 55. Mm-hmm. And when you do those implants and crowns on those 65, 70-year-old grandmas, you don't even comprehend that they still may be alive at 95. Mm-hmm. And you're in these nursing homes, they bring them in, and they're all bruised and they're all frail. No one's going to do implant surgery on her. I mean, it'd be frightening to do that. And I'm sitting here knocking myself in the head thinking, why did this whole prosthesis lose because of 1 implant? Where was the spare tires?
Yeah.
Where was the true implanting? And that's another thing the young kids don't realize. They'll sit there and they'll see an old guy and they'll think, well, I don't want to fix them all up because she'll probably only live another couple of years. And now 10 years later, he's still in your practice.
Hey,
20 years later, he's still in your practice. I'm telling you, they don't die. They don't die. I mean, and
I have patients that come to me that are in their 80s and 90s, and they're losing their first tooth, or they're missing a couple teeth, and they come to me for an implant consult, and they say, "Well, am I too old to have an implant?" And I said, "Well, first of all, you look like you're in really good health for 80 or 90 or whatever age you may be. Okay, you've got some minor medical problems, but you're probably going to be around for a long time. So let me ask you this. What do you want your quality of life to be like? Do you want to be wearing a removable partial denture, or do you want to have some implants so that you can really enjoy your food and have a good quality of life? If you're willing to make the investment in a little bit of time for the implant healing process to occur and some money, I think you're going to enjoy things. You're going to have a much better enjoyment of your life for the remaining years that you have, whether it's 5, 10, or 20. And so it's that discussion that you have, that consultation with the patient is so important. Patient consultation, patient selection, and just giving the patient all the different options. There is no one way to do things, and giving the patient those options really does result in a better long-term result.
So you had the first CBCT CAD-CAM combined because you were using the CAD-CAM not to make Empress crowns. You were doing it to make surgical guides.
Exactly. So I was the first specialist in the U.S. to have both CAD-CAM and cone beam and a milling unit in the office.
And how big of a surgical guide can those things make these days?
I actually don't use the milling unit to make surgical guides. I actually have a 3D printer. So when I can make the surgical guide in the office, then I use my 3D printer.
And what 3D printer did you go with?
Currently I'm using the Formlabs. The Formlabs Form 2.
Can you send me that, Ryan? Formlabs? And where are they out of?
They are out of, I think they're Boston area.
And do you think surgical guides are better to be milled, CAD-CAM reduced down, or printed up?
I think the accuracy, of all the different techniques is the same. What's different is operator. So you want to make sure that, and I tell people who, for example, the course I'm teaching in Scottsdale tomorrow, Advanced User Training for Galileos, we're going to talk about doing CEREC milled guides. I tell dentists, don't make a CEREC milled guide until you've done at least 25 guides that were made for you. Okay? Don't print your guide with a 3D printer until you've made you've done at least 25 cases, because you're not going to know what's good and what's bad. It's like, why did we learn to wax up a denture in dental school? Not because we were ever going to do that when we got out, but that's how we learn what's good and what's not. So you don't need to print your own surgical guide. You don't need to mill out your guide. There's plenty of companies that will do that for you fairly inexpensively now and with a pretty quick turnaround. If you want to do it yourself, if you want to have that control of doing it in your office, do it. Just make sure you've got, 25, 30, 50, 100 cases of having someone else make the guide for you under your belt before you embark on doing it yourself. And remember, it's going to take you more time if you do it yourself.
I cannot believe we are at an hour and 7 minutes. We've gone overtime.
We've gone overtime.
Any chance, Dentaltown? You have courses on Dentaltown.
I do.
How many courses do you have on Dentaltown?
I think about 7 or 8.
Yeah. By the way, Jay's man. You were not only the first online CE course to hit 10,000 views. You were the first 3 courses.
Yeah.
You did 3, boom. Remember you made it with Rita?
Yeah.
My God, he was the first guy to have 10,000 views.
Yeah, well, I was
the second guy to also get 10,000
I was
views.
one of the first CE courses. Me, Marshall White, and who else did the first one? I think
Marshall
the 3 of
White.
Didn't he do the first?
Yeah.
Yeah. And then one more. I think there were 3 courses that you launched with, and mine was one of them.
Was it Annie Koch?
Okay.
But and she was the first endo course to hit 10,000 views.
Wow.
Did you ever listen to Koch and Brave lecture?
I don't think so. No.
They were just workhorse, man. They were lecturing every weekend for decades.
Wow.
Just total workhorse. But hey, seriously, you're a friend, a mentor. You've helped so many dentists. I mean, I couldn't think of a Dentaltown. It would be missing so much if it wasn't for you. I mean,
thanks,
you were
Howard.
the oral surgery. You were the helicopter oral surgeon hovering over that group, keeping so many people out of trouble, answering so many questions. You're so generous of your time. I just love you to death. Thank you so much for coming over by the house. Go to onlineoralsurgery.com.